special where you will hear much less of me and much more of one other person who will introduce himself in no short order. But in true global virtual morning report tradition, I wanted to remind you that I am originally from a small town called Zahle outside Beirut, Lebanon, where we speak Arabic. And in Arabic, we say good morning, Sabah an-Nur, which means welcome to the light, which I find very, very nice. Unfortunately, there's much light to be desired here in cloudy San Francisco, but hopefully my dear friend Kirtan can bring us the light today with his magical facilitation. But before we do that, I'd love to introduce everybody else on the CP Solvers team. We'll start with Anne-Marie.
Hi everyone, happy Saturday. I'm Anne-Marie. I'm a hospitalist. It's so good to see everyone here today. Oh, I will pass the mic to Kiara.
Hey friends, I'm Kiara from Peru. I'm also happy to see you today, and we have a case. And also I want to show the strange position. So Maria, can you say hello?
Hola, my name is María, soy de Guatemala y pues estoy feliz de estar aquí con todos, hablando un poquito de español y yeah, I'm really excited to be here. Gabriel, why don't you introduce yourself?
Hi everyone, very happy to be here today. My name is Gabriel, as well as from Kiara. I'm from Peru, and also I have a little dog. It's a Peruvian hairless dog. They are native from this country, and they are very cute. They have no hair, so it's well for my allergies. And they are like always warm and shaking. I love him. I'll pass the mic to Gabi.
Hi friends, I'm Gabi, I'm from Brazil, and it's very good to be here. I'll be doing teaching points today. I will try to write at least 10% what Kirtan teaches us because he knows a lot, so let's see how I do. And I think you can introduce yourself, Kirtan.
Yes, hello, good morning everyone. It's my first time being a facilitator here, and I hope that I can recapitulate what the Maria did previously, because it was, kind of blueprint for us. It was so good that we have to follow the trail that she left. And before we move forward, I just wanted to ask Rabi that recently you have changed your Twitter name and it says Furfur. So is it related to Malassezia Furfur or is it something different? Please tell us.
So Maria and then you were the first people to ever ask me. And unfortunately, I will tell you that the answer lies in the most recent RLR episode. So anyone on the CP Solvers team, all you need to do to have access is to email me and I'll send you the episode. If you're interested in knowing the answer to this dilemma, consider subscribing to our Patreon, because this is highly personal information that I only hide behind the Patreon paywall. And that is the answer to your question. But thank you for asking, my friend.
Yes, that's so spooky. I mean, it sounds so mysterious. And well, I'm happy to tell you that we have our dear friend, Franco, who was recently introduced by our team member, Kiara, who has a case today. And the first ever case that Franco presented was that of Bigos disease, super rare, super mysterious vasculopathy. So I'm so excited for today's case. I hope that we can crack the case because I'm sure it would be a difficult case to crack. And if Franco is here, maybe Franco, you can unmute yourself and introduce.
Hi everyone, I'm Franco. I am a Peruvian MD. And today's case, I think it's a very educational case, and I will love to everyone to give their insights about it. So I think it is an emotional case.
Wow, that sounds exciting. So, well, let's start, and maybe we can share the screen, and I will try to highlight everyone's voice as much as possible. And if you are in a place where you can unmute yourself, then please share your thoughts. And if you think you can't unmute yourself, then it's totally fine. We will try to highlight your comments in the chat too. So it's totally fine, and let's see how it goes.
Great. So for the chief concern, we have a 42-year-old female who presented with a 3-day history of left flank pain alongside with left lower back pain. I think it's a good start for someone that wants to discuss it.
Sure. Thank you so much, Franco. That was really a nice place to start. And well, we will give a few seconds for chat to mention their thoughts. And it seems like a common place to start. We have got a flank pain, we have got a lower back pain. It's a female, so we have to factor in the gender itself. We have to factor the chief complaint, and then we'll move forward. So let's wait for 10 seconds.
Hi, can I share my thoughts?
Sure, Daniela, we would love that, please.
Hi, everyone. First of all, good morning. I believe that in a female patient, it's important to consider a source of pain that is from the reproductive system. So I would definitely check to see if she is pregnant, do a test on that, and of course consider other causes of abdominal pain. But at first, that would be my first thing to consider, and I'm sure that everyone else has other thoughts.
That's excellent, Daniel. I absolutely love that, because in female, before going for extensive workup, it's always necessary that we look for pregnancy, because if you miss that, then in ordering investigations, you could harm the fetus as well as the mother. So it's absolutely essential. And we have a new face here. So we have a Carmel Martin here, and I think we haven't had them before. So Carmel, do you think are we in position to unmute yourself and please share your thoughts? You have something about renal pathology. So please tell us, what are your thoughts?
Hello everyone, I'm Carmel Martin. I'm from India. So left flank pain with back pain actually makes me think of any renal pathology, like even a stone, something like that.
Yes, sure. Carmel, and do you mind telling us from which state you are calling? I'm also from India, so let's see where we are coming from.
I'm from Kerala.
Right, sure. And which year of medical school are you currently in?
I have just started my second year MBBS, so
sure.
I'm actually
good. Yes, and any fun thing that you want to share about yourself, like what's your favorite food, what's your favorite weather like, something like that? Yeah, I don't mean to put you in a spot. It's totally fine. But thank you for being here. And you are definitely right. Renal pathology is something that we have to consider. And given the fact that we have a flank pain, it definitely could be something like kidney stone. So we have to look out for that. And then Ravi has a beautiful thought that how we can anatomically approach the left flank pain. So Ravi, do you mind unmuting yourself and share your thoughts?
Hi, Ketan, how are you?
Yes.
Yeah, today, actually for the next 2 weeks, I'm at my mother-in-law's place out in LA. So same time zone as Ravi, West Coast. So I would approach it, externally many times, like chest pain. I've been sidelined or blindsided by something like shingles. So it could be something on the skin like shingles. It could be something externally on the skin, bruising or something like that. You go then down to the layer of the muscles. You could have a pyogenic infection within the muscles, iliopsoas, abscess, something of that nature. Could have a spontaneous hemorrhage, maybe hematoma. And then you have the large pocket where the kidney could reside in the retroperitoneum. So the kidney could have something like a kidney stone, somebody mentioned, which is a great thought. The pain is tremendous. You could also have infection, pyelonephritis, or maybe a malignancy or something from chronic pyelo, something called xanthogranulomatous pyelonephritis. Other things could be something involving the vessels, maybe the spine itself, So you want to look for maybe metastasis to the spine, there may be neurological consequences of that, or there could be something ominous like a epidural abscess. So just a few thoughts. I think there's many others that other people would like to share.
Yes, thank you so much, Ravi. I absolutely love that zoster idea, because just a few weeks back, we had that thing in our differential that what if something is related to the musculoskeletal pathology rather than the abdominal pathology, and even the spinal cord thing, because often we think about the aorta, aneurysms, kidney, everything, but we forget that spinal cord also releases the nerves which travel all the way to the anterior part of abdomen. So it's absolutely essential to rule that out. And then I see Arisha here. Arisha is a frequent flyer on VMRs. So Arisha, you have some thoughts about kidney infection. Do you mind sharing them?
Yeah. Hi, everyone. I'm Arisha. I thought that flank pain is very commonly caused by kidney infections and GI diseases, whereas kidney stones are also a very common cause of flank pain. So that's it. That just came in my mind as the most common cause.
Yes, sure, definitely. It's a nice thought. And now, before we move on to the next aliquot, I would just like to ask Rabi a little bit. That Rabi, whenever we face the left flank and back pain, apart from the organs that we discussed so far, do you think there is anything else that we have to look out for?
No, I think it's absolutely marvelous. I don't think I have anything to add to this thought process. It's actually my first time hearing Arisha's voice. Arisha, where are you calling from?
I'm from India.
Oh, whereabouts in India?
Same as Nelayan's college, Maulana Azad Medical College, Delhi.
Amazing, wonderful. Thank you for your brilliant thoughts and for joining us. I have nothing to add, Kirtan. That was marvelous. I'm excited to learn more.
Sure. So Franco, do you mind giving us some more data?
Okay, perfect. So we are having a great start here. So a little more about the history. So I already say that it's a 42-year-old female who presented to the emergency department after having left lower back pain that began 2 days prior to admission. The pain initially did not improve with NSAIDs, and it was irradiated to the left flank 1 day prior to admission. She denied nausea, vomiting, no bloody stools, no diarrhea, no urinary symptoms, no genital bleeding. Her last menstrual period was 1 week ago, and she already had a test. They took 2 urinary home pregnancy tests that were negative, 2 of them. Regarding her previous medical history, she did have some previous studies of left renal microlithiasis, but she never saw any passage of any gross stones. She was taking natural laxatives for 3 months because she wanted to lose some weight. There were no family history. Regarding social history, no smoking, no drugs, and only a loss of weight of 5 kilograms in the last 2 months.
Franco, before we move forward, can you just clarify that in the past medical history, we have left microlithiasis. So is it something like left nephrolithiasis, kidney stone kind of thing?
Yeah, it was a left renal microlithiasis.
Perfect. Thank you. And do you think this is a nice place to stop? Yes, I think we can move ahead. So first of all, the brilliant thought that Carmel had mentioned in the first aliquot itself, that what if the patient is pregnant? So that we have essentially ruled it out. So that's a nice start. And now the hands has some nice thoughts about what if this is indeed a malignancy? And of course, malignancy is something we shouldn't miss. So Hans, do you mind sharing us how do you think this can fit into malignancy?
Yes, when I saw the red flag, 5 kilogram weight loss, which is certainly unintentional, and that could be maybe a renal cell carcinoma that has even spread to the spine. So we are interested in the urinalysis later on in the labs, as well as ultrasound and the CT pelvis abdomen. There might be something going on.
Definitely, hence I agree with you that renal cell carcinoma is one of the great mimickers. So it can present in so many ways, and we have to keep an eye on that. And our dear friend Gabriel has some thoughts about that. the fact that pain is not improving with NSAIDs may suggest that something. So Gabriel, do you mind telling that what are the ways in which we can approach this case when pain is not responsive to NSAIDs?
Yeah, thank you, Kirsten. So for the back pain, it's usually a common clinical problem that presents during the clinical consults, but usually we have to investigate what are the red flags to investigate more about the problem. Maybe with an image, because usually the images are not specific, and usually we can see some findings that are not related to the symptoms. So in this patient, the fact that she's not improving with non-steroid anti-inflammatory suggests that there is more a sinister cause that we should investigate. So I'll ask for an image, and also anchoring with loose weight. Maybe this patient is from Peru. I'm started thinking about TB or Brucella. And one clinical part that I learned hearing in my university is that usually Brucella tends to affect the L5. So it tends to cause lower back pain in comparison with TB that usually tends to affect the dorsal 12 and L1. So not usually low back pain, but this patient is from Peru, so we don't want to miss TB too.
Sure, I absolutely love that. And if I'm not wrong, a few months back, Dr. Rebecca presented a case in which it was indeed Brucella osteomyelitis and epidural abscess. So thank you so much for pointing that out. And Gabriel, do you mind telling us a little bit in French or Spanish? I'm sorry, French is not your language, but maybe Spanish, you can tell us this Brucella and how you pronounce it in Spanish. What do you think?
Sí, bueno, lo que había aprendido era que Brucella usualmente afecta la columna lumbar 5, entonces usualmente se puede presentar como dolor lumbar bajo, y mientras que tuberculosis usualmente afecta la T2, L1, y esa es una forma de cómo poder diferenciar al inicio entre Brucella y tuberculosis, porque suelen causar una sintomatología muy similar.
That's amazing. I should learn this language, I guess. I am learning, bit by bit from our dear friend Kiara. Kiara always sends me 1 or 2 words on WhatsApp, and I learn it every day. So maybe I can speak that one day. And now before we move forward, our dear friend Mario has a fantastic mnemonic as to how we can categorize the various causes of back pain. So Mario, do share, what is this tuna fish thing? Sounds really interesting.
Yes, hi. I learned it from our Curbsiders episode. And it stands for trauma, unexpected weight loss, neurological deficits, age older than 50, fever, immunosuppression or IV drug use, steroid use, and a history of malignancy. So having those risk factors should prompt further workup for lower back pain.
Definitely. That's really a comprehensive mnemonic. It covers almost every aspect. And now I really wanted to add, a really small fact about why this NSAID might not be explaining the relief of pain. So whenever we think about what if this is indeed an nephrolithiasis, first let's tackle that. So if it is indeed a nephrolithiasis, sometimes NSAIDs may not work. You need antispasmodics. So oftentimes dicyclomine is something which can cause the pain relief from nephrolithiasis. And often it happens that NSAIDs are not, given in the adequate dosage or at the adequate frequency. Sometimes diclofenac may work better than indomethacin or some other NSAIDs. So it's really nice to find out that what specific NSAID was given to the patient. And then, of course, we have to think about what if this is not nephrolithiasis at all. So we have to characterize the pain further. What if the pain is radiating? If the pain is not radiating, then it may not be nephrolithiasis. And what if it is indeed radiating pain? So something in the testis, something in the psoas muscle, something in the retroperitoneum, or as the Ravi mentioned earlier, that the spinal cord pathology, because oftentimes osteophytes are there, nerve compressions are there, and that can cause intercostal neuropathy kind of thing, along with the zoster. That are some of the neuropathic causes of the pain. And I think I have rambled on enough. So Ravi, can you please align our conversations that what are some of the things that we may be missing and how we can move forward?
I think your analysis is spot on. I also love that you taught us how to not just black and white NSAID on or NSAID off, but rather study the nuances. Is the dose right? Is the type of NSAID right? I think that's brilliant. I think that we are now in the space where we are trying to define the problem rather than solve it. And so we still have to define it as a kidney problem, skin problem, bone problem. And so hopefully more and more data will help us define the problem. But since you gave me the mic, I will share some pearls and pitfalls about kidney stones. We use the urinalysis to help us adjust the probability of kidney stones in patients and use hematuria, microscopic hematuria, as a clue to the presence of kidney stones. However, about 20% of patients with kidney stones have no microscopic hematuria. So on the next aliquot, if we get that there is no hematuria, it doesn't mean that there is no kidney stone. Okay, so 20% of patients with kidney stones have no microscopic hematuria. That's one pitfall. Here's the other pitfall. Most people's kidney stones never fully resolve. So the question always is, if we find a kidney stone, is it an innocent bystander to a secondary disease process as a result of a stone that occurred eons ago, or is it the cause of the problem today? It's no different than finding gout crystals in a knee that is inflamed. Once you've had gout in your knee, you will always find gout crystals in your knee forever and ever and ever. So how do you prove that the kidney stones are causing the problem? You see accompanying hydronephrosis. Helps a lot. And of course, the patient gets better with treatment of kidney stones. So remember, when you're diagnosing kidney stones, the UA is imperfect. 20% of patients have no hematuria. And even seeing a stone is imperfect because the stone could have been there a long time ago and the patient have a new independent process today. So keep an eye out for that in this case. All right, back to you, Kirtan.
That was absolutely masterclass, Rabi. You taught us that how to interpret the test in a particular manner. And very briefly, I wanted to mention that Franco told us that the patient is taking pills to lose the weight. Now, if Franco is really being cheeky, then what if that is indeed orlistat, something like lipase inhibitor? And if I am not wrong, that whenever you take the lipase inhibitor, then you cause the fat malabsorption in your intestine. When you have fat malabsorption, you can get something known as enteric oxaluria. So you end up, absorbing oxalate more and more. And I just remember this because Rabi was mentioning about the crystals. So that made me realize that what if it is indeed, calcium oxalate nephrorethesis kind of thing. And that is one nice clue from the history that we can dig in further. So let's see what urinalysis and everything reveals. And now our dear friend Carmel has a thought that what if this is indeed the psoas abscess? And in the initial report, we mentioned about the musculoskeletal pathology. So I think this is a really nice one because we are dealing with unilateral pathology. So Carmel, can you please share your thoughts?
Actually, I don't know much about this. I just studied in anatomy classes that psoas abscess can cause flank pain and back pain. So, but I'm having a doubt, like, won't it resolve with an NSAID? So I was just having a doubt.
Yes, Carmel. Actually, I know anatomy as much as you, only not more than that, because I actually hated anatomy and surgery part. But I absolutely love that in our anatomy class, I also learned this thing that whenever you're dealing with, let's say, appendicitis or diverticulitis, what if there is something more than that? That sometimes psoas abscess can be a complication of inflammation elsewhere in the abdominal cavity. So I guess psoas abscess is really a nice thought. And the fact that patient doesn't have fever until now doesn't rule out that thing. We need to have imaging studies and certain, maneuvers like flexion and extension of the hips and knee joints to find out whether it is indeed a psoas abscess or not. So I think that's really a nice thought. And so far, I think we are doing great. And let's hear more from Franco that what are the things we can hear from vitals and everything else.
Great, perfect. By the way, I love your pair about lipase inhibitors, Kirtan. It was great. It was like some sort of a Crohn disease picture of oxalate crystals. I love it. So, okay, for the vitals, the patient was on admission without fever. The temperature was 36.5. The heart rate was 60. Blood pressure was 100/70. The respiratory rate was 18. The SpO2 was 98 on room air. Regarding the physical examination, it was pretty non-contributory, except from the abdomen that had a mild tenderness to palpation without warding, no rebound, no masses, no organomegaly, and the bowel sounds were present. There were no deficit, neurological deficit, no rash, purpura, or petechia. I don't know if you want a little more of the initial labs or we can stop there.
Yes, I think Franco, if you can give us just a little bit of like CBC, and I think that would be best.
Perfect. So for the CBC was normal. There were no alteration in hemoglobin, leukocytes, or platelets. There were normal electrolytes. The creatinine was 0.47. The urea analysis had no leukocytes, no blood, no germs. Also, the C-reactive protein was 1.36. All normal values were up to 0.5, so it was slightly elevated. The erythrocyte sedimentation rate was 35. Also, we have, I can give you a little more, I guess. The AST was 35, the ALT was 20, normal bilirubins, the INR was 1.2, the D-dimer was 0.7, the alkaline phosphatase 107, the GGT 48, amylase 53, lipase 7, HIV negative, lactate of 9.2, LDH of 178. I think we can stop there.
Thank you so much, Franco. That's really helpful. And before we can analyze the examination and the lab findings, the Nilayan has some nice thought to share about the oxalate stones, which Franco just a few minutes ago mentioned. So Nilayan, please share your thoughts that how IBD can cause renal stones.
Hello, hi Ethan, hi Rabi, hello everyone. So yeah, I really expanded upon your point, as you said, that orlistat causes lipase, causes lipid malabsorption, and that I thought that maybe lipid malabsorption causes calcium to chelate with lipids, and that really makes oxalate, frees oxalate to be freely absorbed by the small intestine, and that oxalate freely absorbs and then it's filtered by the kidney, and that's how the oxalate stones are formed in the context of lipase inhibitors. And I think something very similar happens in IBD. So there is a loss of calcium in there, and that usually what happens is calcium chelates with oxalate in the lumen and prevents the oxalate from absorbing. But in IBD, that doesn't happen. So there's a loss of interstitial calcium, and then so that makes oxalate free to get absorbed and form oxalate stones. So this was a really cool connect I learned in second year, that IBD can cause renal stones.
That's absolutely fantastic. The way you explain the pathophysiology is really interesting. And Nilan, can you share what you just said in Hindi? Because, you know, I also like Hindi, but we know that in different states of India, Hindi is spoken in different manner. So can you please tell us briefly your thoughts in Hindi?
Oh my God. Okay, I'll try. So ऐसा होता है कि small intestine, I don't know Hindi for that. So small intestine के lumen में in IBD calcium absorption जो होता है वो calcium absorption नहीं हो पाता. So calcium जो होता है वो lumen में ही रह जाता है and उसका wasting हो जाती है. So this जो oxalate होता है वो it becomes free so that वो lumen से absorb हो जाता है and फिर lumen से blood में, blood से kidney में, and then kidney stones.
Perfect. It's, you know, typical Hindi-English combination that we use in India. We can't specifically tell everything in Hindi. So that was perfect. And yeah, I really like your point that what can cause this. And from the examination, as far as we are here right now, we don't have much clues because there is mild tenderness to palpation, but there is no evidence of rebound tenderness or rigidity. So that kind of moves us away from peritonitis. But still, it's something we have to consider because sometimes if patients are immunocompromised, they may not develop the signs of abdominal inflammation that we anticipate, but it certainly is lower on our radar as of now. And the fact that the LDH is a little bit raised and the CRP is a little bit raised also raises concern. And now Ravi mentioned amazing thing that what if the LDH is somehow related to the hemolysis? So Ravi, do you want to share your thoughts about how to make sense of LDH in this case?
Yeah, hi Keaton. Is that correct? It's was the value 178? Is that the correct value?
Franco, is the 178 correct and is it elevated?
About what? I didn't hear.
The LDH.
Yes.
the LDH, yeah, 168 and 78, and it was normal according to lab values.
Oh, okay, it's normal. Okay.
All right.
Yeah, but if you want to talk about the LDH, my sort of thoughts were if there was a hematoma, which, if you tackle hemolysis, you have a massive amount of LDH release, but hematoma could cause an elevated LDH. But LDH also emanates from kidney, liver. I doubt spleen. Spleen is also on the left side. So if you have a splenic infarct or splenic hematoma, that could raise it. But this sort of may exclude all of these processes that I mentioned.
Yes, thank you so much, Ravi, for sharing that how splenic pathology can explain the elevated LDH. And the lactate is actually 9.2. So, Franco, if I'm not wrong, that is elevated, right?
No, according to our lab values, it's normal until 11.
Okay, I see. No problem there. So, Ravi, do you want to tell us that now what to make sense of these labs, which are mostly unremarkable? So how to make further progress? And urine analysis didn't show the evidence of blood cells or any pus cells that we were looking for. So now how to move ahead?
I think this is very realistic of real life. Flank pain is very, very challenging. And if you try to make an analogy with our approach to chest pain, the patient with flank pain gets an immediate analysis for how ill they are appearing. And anyone with flank pain who appears ill is diaphoretic, tachycardic, almost always needs cross-sectional imaging with a CT scan to understand what's going on. No different than a patient with chest pain needs sometimes CT scan to know what's going on outside of an EKG. And so here, if you look at this, you're like, this patient is young, otherwise well, and has a normal exam and normal labs. Why would you proceed rather than empirically treat and let it be? And I don't know. I think many causes of flank pain are musculoskeletal NOS, and the only way you can make that diagnosis is to be confident that there are no kidney stones, which is a good case here. The patient is non-toxic appearing, the pain is not colicky, and the UA is negative. However, in parallel to that is the fact that you don't have a clear diagnosis, and this is something new and novel for the patient. So what would happen in real life? In real life, you might say, this is a well-appearing patient without a clear cause, but no red flag findings. So I will watch to see what happens to her and keep an eye on her. But also in real life, you might spend some time saying, well, what are the gaps in my schema? And we already talked about very good approach to flank pain. Kidney causes, superficial causes, lung causes, gallbladder, spleen, vascular causes, adrenal causes, which aren't happening here, and pelvic causes. My dog isn't very happy about this schema. So what are the gaps? The gaps now are a pelvic exam. Does this person have ovarian torsion or ectopic pregnancy, which we ruled out? Or does this person have a vascular issue? So if I were to discharge this patient with supportive care, I would plug those gaps and consider doing a pelvic exam to see if the left flank pain is actually adnexal tenderness, and do a good pulse exam to make sure that we're not missing subtle vascular pathology. But absent that, this is what happens in real life. You don't really know what's going on, and the best diagnostic test is time. So that's where I'm at in this case.
Yes. Thank you so much, Ravi, for aligning us on the way, because I was also lost. And actually, after hearing your thoughts, I have an idea that actually Franco discussed an amazing case on the Wednesday VMR, I guess, which was presented by Dr. Rebecca. And in that case also we had flank pain, and urine analysis was clear actually, but indeed it was a case of renal artery dissection. So it was a reminder that how sometimes vascular problems can present suddenly and may not present on urine analysis in the way that you anticipate. So urine analysis can be bland initially, but still you may be dealing with vascular cause, and things like renal artery thrombosis or renal vein thrombosis can be something that we have to consider. And definitely we would want to get imaging studies like USG or CT scan to look for the evidence of nephrolithiasis or hydronephrosis or any mass which is compressing on the kidneys or the pelvis, which might explain the pain that we are dealing with here. And before we move ahead, Anne-Marie has a thought about that ULN on labs. So, I mean, we have talked about this, that how upper limit of normal can change. So Franco, can you just tell us a little bit about this lactate thing, that what are the ways in which lactate is measured in your institution?
Oh, lactate is milligrams per deciliter. So the normal value is up to 18 for labs. It's venous lactate.
All right. Okay. And Franco, how many more aliquots do we have?
Yeah, we have, I think we have two more, one for the imaging and one for the last one, that will reveal the
Yes.
diagnosis.
All right. So do you mind giving us more data?
Okay, so we actually did what Ravi said. We wait and see for the patient. The pain got worse. Meanwhile, we took some imaging of her. So we have some contrast CTs. The findings were left renal microlithiasis, no distended ureters, no hydronephrosis, a small fluid around the gallbladder, no lithiasis, asymmetric contrast uptake of bilateral ovarian veins with partial filling of the left ovary vein, non-conclusive for thrombi, right pleural effusion, and we also have a transvaginal ultrasound that show echographic signs of pelvic congestion, multiple variceal veins around the uterus, and a small amount of free pelvic fluid.
All right, so we have a lot to deal with and very surprising findings. So before we discuss that, just before the Franco gave us this data, Hans had a thought about renal cancer as well as how we can deal with the weight loss, because the patient is taking the weight loss pills. So we might not consider the weight loss as something related to malignancy, but still it's something we have to consider. And now given the fact that we have surprising imaging studies, it makes point. So Hans, do you want to tell us more about this renal cancer thing?
Yeah, but I have to say that I missed the meds, pills to lose weight. Of course, then it is an intentional weight loss and it does not necessarily indicate anything of red flag. But here we might look at, if looking at the contrast, that there are some vascular problems involving the uterus and the pelvic organs. So that is interesting. And that could in part explain it's still normal, but the high normal LDH, lactate and LDH. So there is some ischemia probably taking place, or congestion of venous blood from thrombosis emboli.
Yes, definitely. I agree with you that I have sometimes come across something known as ovarian vein thrombosis, which can present as, orthostatic pain, but I never thought that it would present in the unilateral way. So it's really surprising. And Ravi, do you want to tell us that how to make sense of this critical data and bit of tricky data?
Oh my gosh, wow. Wow. Do you all feel that tension in this case where you're like, I don't know where this is going to go? And I think it's okay to acknowledge that. I think all of us, like, you know what, can I tell you what I noticed? I noticed the chat almost go silent. I noticed Kirtan start to spin his wheels really fast. Like, whoa, what could this be? And that's okay. That's okay. It's totally okay. This is what happens in real life. In real life, we feel very confused and very troubled. And Franco, I want to commend you for pushing further. I think in real life, a lot of people might have missed this diagnosis. And this is very, very remarkable that you caught this and are progressing further. Can you just tell us again, so the CT showed just distended ovarian veins or thrombosed ovarian veins?
It was just congestion and distended, non-conclusive for thrombosis.
Okay. Yeah, I think Kirtan, I think we're confident that everything now collapses into the following question. Why are the bilateral pelvic veins dilated and under high pressure, be it with a clot that we cannot see or because of venous hypertension without a clot? And maybe we can pause there for a few seconds to see what folks have either heard of or come up with their experience, like what have you heard of as causes of bilateral ovarian or pelvic vein hypertension? And if you have something, please let us know soon because my list is very short. Kirtan, look at my dear friend Ravi. He says, I have no list. It's true.
Yes, but yes. Yes. I mean, despite the fact that, yes. I mean, despite the fact that he is telling that he has no list, he mentioned a nice part that how we can link the plural of fusion. So Ravi, do you want to tell us that what are your thoughts on this mixed syndrome, ovarian pathology, ovarian tumor? What do you think?
Oh, hey, Kirtan. Just that pleural effusion, I think Anne-Marie talked about that pleural effusion issue, and I was like, wait a minute, there's something called Meek syndrome where you have a benign ovarian tumor, ascites, pleural effusion. So it sort of reminded me, it's like something just sets off a remote sort of thought, and pearls or other things come up. So I sort of had a knee-jerk reaction to that. But yeah, my knowledge sort of is limited in this area. So as Ravi mentioned, maybe a consult with Gyne or further exploring with like a reference like UpToDate would kind of.
Yes, absolutely. I agree with you, Ravi, that in this case, if we can't move ahead and if we are not sure of the final diagnosis, it's definitely nice to consult the OBGY. And really, the bilateral distended veins make me worry that why it can be distended. I mean, usually it happens when the drainage portion of those veins, so like ovarian veins is ultimately drained with the inferior vena cava. So if something is wrong with, let's say, inferior vena cava or portal circulation, so if there is thrombosis there, if there is a mass there, and let's say portal hypertension is there, some kind of congestion is going on, then that can cause bilaterally distended ovarian veins. And the fact that the contrast uptake was also asymmetric is also a bit worrying that why it would happen. So are we dealing with ovarian malignancy or something like that? Because that is something usually presents above 50 years of age. It's not usual to find in 42-year-old female, but definitely we want to keep it high on our radar that we are not missing the ovarian malignancy. And Daniela, you were kind enough to mention that you can translate our PR into Portuguese. So please do it.
I'm already doing it. I'm just typing it out.
Yeah, no problem, no problem. Do you mind us speaking a bit of it so we can understand Portuguese?
Okay. Should I just do the problem representation? Maybe a summary?
Okay. Yes, that's perfect.
Então, nós temos um paciente do sexo feminino que tem 42 anos de idade e ela apareceu na emergência já com 2 dias de dor no flanco esquerdo e também na região lombar, à esquerda também. Deixa eu ver o resto do resumo que o Gabriel fez, muito bonito, inclusive. Os exames de rotina, que eles chamam em inglês, né, de painel metabólico, foi normal e a tomo mostrou uma congestão das veias ovarianas e também foi apresentada uma, acho que em português também se chama efusão pleural, então um líquido na região direita. Acho que é isso. Se alguém tiver alguma dúvida, por favor, me manda uma mensagem. Obrigada. Okay, that was it.
Thank you so much, Daniela. And I think for the sake of time, we can ask Franco to give us the final piece of data and then we can weigh in our final diagnosis.
Okay, perfect. So we were also scratching our heads with this patient because we actually didn't have a clue. So we ended up consulting surgery and OBGY, and the patient went to the operating room. So in the surgery report, we find out that she got a torsion and necrosis of the left fallopian tube, edema and torsion of the right fallopian tube, acute lithiasis cholecystitis, and the ovaries were normal.
Wow, what a fascinating thing. We were, anchoring on the ovarian part, and then the imaging studies didn't reveal much. But you are right that we have to even consider the fallopian tube, that they can even torsion and they can cause this. And cholecystitis is a bit surprising. But Ravi, do you have something specific that why we shouldn't miss this, and what are the ways in which we could have identified it earlier, this fallopian tube torsion? Do you have some pulse about that?
I think this is a very humbling case. And a reminder, if you go back, and I don't know if this is on our website, and if it's not, I will work to get it there soon. But I think you have to respect pelvic diseases as a presenter of flank pain. And I think in the world of UA negative, exam negative, concerning flank pain, a pelvic exam is crucial. And let me just show you. So we did a UA, we got some imaging, and you really, really have to entertain this possibility here. And this possibility is really, I think, emphasized by the acuity of the presentation. When somebody has acute flank pain, you really, really have to do a pelvic exam. Unfortunately, the pelvis is a very hard location to get definitive imaging quality. I work in a VA where men are much more common patients than women because historically, hopefully this is being corrected slowly, but much more men have served in the US military than women. And so what I see less commonly is testicular torsion. And you can see the findings of the venous changes in the testes that react to the torsion. And so I suspect that the venous reaction here was just the inflammatory reaction to the torsion of the ovary. So what can you take away from this case? Well, one, I think Franco just humbles us every single time with mind-blowing cases. But don't walk away from a case of flank pain before discharging a patient without examining the pelvis. And I think that if I were more comfortable examining the pelvis, which I should be, I think you would not discharge this patient and you would find a way to the answer. And just know that imaging is not perfect, and ultrasound is better than CT, and MRI is better than both. But the good old-fashioned way of just looking with your very eyes in surgery is the best. And I think Franco taught us that very important lesson today. Maybe you can share your thoughts on what you learned from this case, Franco.
Well, actually, I have a picture of intraoperatively, so everyone, I can share it if you want. I don't know if I am. I'll send it to Kiara.
Oh, there we go.
So yeah, that was our case. So we learn about this. I learned a lot about this case regarding of distinguish the causes of medical abdominal pain and surgical abdominal pain. And when something doesn't get right, some doesn't fit any scenario, you have to go with the algorithm to discard the most common causes. And if something is not quite okay, you need to call the surgeons and you need to go in there. It's better to have something that we say a lot here in Peru. It's better to have a white laparotomy instead of something that is going to get worse. And in Spanish es mejor tener una laparotomía en blanco a tener un paciente que se complique después.
Perfect. That was awesome. And before we conclude and pass the mic to Gabriela for teaching points, I just wanted to mention one nice thing which Reza taught us, I guess, few weeks back, that whenever you are dealing with acute pain anywhere, let's say it's chest or let's say it's the abdomen, you always have to think about rupture, dissection, torsion. And he told us that be it anything, let's say it's esophageal will rupture. Let's say it's aorta will dissect. Let's say it's fallopian tube. So if we think about it, fallopian tube is also a hollow organ. And maybe if it, let's say, undergoes torsion, then it will also cause the pain in very similar way we think about other pathologies. So Reza taught us very nicely that day that how we can think about the acute pain. So really nice case, really humbling case. Thank you so much, Franco, for bringing it. And maybe you can give us, a little bit easier case next time because your cases are getting tougher and tougher every time. So please do that. And my dear friend Gabriela, do you mind sharing your teaching points today?
Hey, Kirtan, the same could be said of your cases.
Yeah, totally agree with that. Thank you, Franco, for your case. It was a really good one. First, we talked about a little bit the localization of the back pain, and we learned that we have to look for skin lesions, for example, bruises or shingles. We have to look for muscle infection, like a pyogenic infection or abscesses, and also hemorrhage or hematoma. Kidney can also cause back pain, for example, pyelonephritis, even acute or chronic, and also vessels and spinal cord diseases like metastasis and epidural abscess. And we also learned that in female, flank pain can be due to a pregnancy or complications of pregnancy. And we have to exclude pregnancy because some exams like the CT could harm the baby. We also learned about some red flags for back pain, which is a mnemonic tuna fish. And this stands for trauma, unexpected weight loss, neurological findings, age more than 55 years old, fever, immunocompromised, steroids, history of HIV, TB, or cancer. Also, Rabbi told us about some pearls about kidney stones, which are first that microscopic hematuria, it's only present 20% of patients with kidney stones don't have microscopic hematuria. So if you don't find it, it doesn't mean it's not kidney stones. The second one was that a kidney stone on CT may be an incidental finding from a prior stone and does not prove that the current syndrome is from the stone. And the third one, if you find associated hydronephrosis, please favor that kidney stones are the cause of the problem. And also we talked a little bit about real life medicine because sometimes we need time to see what the diagnosis is. And we have to give this time to the patient. Some points to consider are exclude severe cases. For example, when the patient is looking ill, which was not the case in this scenario because she had almost a normal exam and normal labs. And also exclude pelvic causes like ovarian abscess and torsion with a pelvic exam. Thank you for the case and thank you for everyone because this discussion was so great. And Kirtan, you did an amazing job with being the discussant, organizing the discussion. So thank you.
Y'all, Rafa is up next week. And a poor guy. He has Maria and Kirtan to follow shoes. And Franco, if you have a case to bamboozle Rafa, we'd be very, very honored. Thank you so much, everyone. And we look forward to seeing you any day this week, but especially next Saturday. And again, a standing ovation for Franco and Kirtan. A marvelous conversation today by you both. Bye.